Thank you very much for being here. Great congratulations to our friends, Emmanouil. This is very nice to have you here in Athens. And we're not allowed to, to go abroad. We come here in Athens and see you in this Congress. Thank you, Emmanouil. So my task is talking about the biceps and how I try to use the biceps in the rotator cuff tear. So sometimes, of course, we speak about tears that are massive or large tears, and we know that with the biceps, we do some tenodesis, tenotomy, we discuss about where to denodise or modify techniques. And this is the classical daily thing we do on the cuff. So LHB, we sacrifice the tendon, and we know that in patients more than 40 years old, maybe the proprioception or the biomechanical work of this tendon is not so crucial. So most of the times we sacrifice this. And when we have this tendon, many years ago, someone said, why not to use this tendon? And many techniques are associated with rotator cuff repair and the biceps. So the biceps is an autograft, so there's no immune response. We have it on the same operating field when we do arthroscopy. It's cheap, and the infection rate is not high, it's a low infection rate. So the techniques we use with the rotator cuff tear and the biceps, first is the augmentation. It's not something new. It's about 25 years ago. You see in this paper, 31 patients with open arthroscopic rotator cuff repair. There was a high healing, about 65%, with good clinical results. And this is a report that the biceps augments the rotator cuff repair. And you see, in 1974, so many years ago, also there was a discussion and a thought about augmentation of the biceps, leave it on the glenoid side, tenotomize on the humerus, and by this way, there is an augmentation of the cuff supraspinatus or the anterior part of the infraspinatus, and on the same ways coming from the Burkhardt, that they leave the biceps there intact, and they do this marching convergence with augmentation of the anterior part of the supraspinatus. And of course, there are so many other techniques with arthroscopic biceps augmentation. And the goal is on rotator cuff repair is not to have tension. Everybody knows that. So biceps, maybe it's a solution in order to repair the cuff with no tension, because we need the repair with no tension with better clinical results. Of course, there are some questions about biomechanical positive things when we use this kind of biceps, but it's not clear. So the message is not clear by these studies because there are few patients, and this prevention of superior migration of the humeral head is still controversial. And of course, this augmentation in some other papers in clinical results, there are some good things that coming from the clinical aspect of the patients, but there's no significant differences. So the recommendation was not to spend much time and effort when you want to augment the tendon of biceps. So the messages from the augmentation are not very clear. What about the biceps using as a patch? The patch is the internal spleen. That was an idea many years ago, using the biceps as a spleen between the cradle tuberosity and the edges of the rotator cuff. Of course, you use some more tendon-to-bone contact, decreases again the tension of the repair site, and somehow you try to retense or reform the balancing anterior and posterior forces of the shoulder. And you see here an old paper, you see the biceps that's open there as a patch, and this is another way to use the biceps in order to gap between the tendon and the cradle tuberosity. Of course, these papers, they have few patients, there's no control study, and the messages are not very clear about the patches. The rotator cable, that was the last 15 years, and this is something crucial, maybe most important biomechanically. This is the thinking, as we know, in the rotator cuff. This is a cable attachment that is more medial on the supraspinatus footprint, and it has to do with biomechanical role. It works as a loaded suspension, and also it's a primary load-bearing structure. And we know that when we do rotator cuff repair, most of you, they look for the cable, And you know that if the cable is there, you can repair the cable. Maybe you have a better result when you do rotator cuff. So rotator cuff disruption has to do with some more tears, of some failures, maybe some more progressive in the natural history of the rotator cuff. And looks that when you have a reconstruction, or when we can reconstruct the anterior cable, we can normalize somehow the superior migration, we can have less subacromial contact pressure, and we can have an improvement on rotator cuff tendon repair by providing, some static ligamental support. And maybe you have a better biomechanical kinematics around the shoulder. There are arthroscopic techniques that they use this reconstruction of the anterior cable and may help to alter the progressive natural history of the tear pattern and decrease the chances of the repair failure. As you see here in these pictures, the biceps is used in order to reconstruct the anterior cable. The scaffold has to do something with biomechanical effects and not so as a mechanical thing. You see that the biceps in this paper that is opened and uses as a scaffold and has to do with some biological positive properties like the dimension of the biceps, the porosity, some mechanical characteristics, extramaterial components, and some viable tenocytes. And this biological active construct may help to improve the quality of healing and regeneration at the repair site of rotator cuff tears, and especially in the case you have a re-tear. We heard before about the RCR, about the work of Mihata. We know that superior capsule is crucial, and when we have a defect on the superior capsule, we have an increased glenohumeral translation in all directions, and this is associated with the massive tears of the rotator cuff. We know the papers and the work from Mihata that the superior patch restores superior stability of humeral head. He used the fascial adjust, as we heard before, and these are the clinical papers with the healed autograft groups. This is the work. What about the biceps? This is the work from the French team and Barth and Achilles. They used the long head of the biceps in order to reconstruct the superior capsule. They leave it on the glenoid side, they tenotomized on more lateral. And of course, this is ineffective. This is a time-saving procedure. This is a low donor side morbidity. If you have the biceps there when you do an arthroscopy, it's an easy technique. And it looks with some clinical good results. And this is a biomechanical study that somehow recenters the humeral head on the glenoid when you fix the biceps on the created tuberosity. This is the superior capsule. You see the anatomy. This is about 30 to 60% of the created tuberosity. This is the insertion, as you see there. And this is the idea of Barth using the biceps and somehow partially repair the superior capsule with this kind of technique. And the other idea was the box technique. You can see different configurations in the literature, like V-shape box technique. You see, this is the double strand. This is two strands of biceps using for superior capsules. So that means you have a more part of the tendon that replicates the superior capsule. And it seems in the literature that it's an effective thing because this double bundle is a strong reconstruction, as you see this in this paper. The length of the biceps that you need if you try to go for the double bundle is about 10 to 12 centimeters. And there are some results from the Denard papers that if you see this anatomic paper, the biceps from the glenoid to the musculodentinous junction is about 12 to 14 centimeters. So that means if you go and tenotomize in the junctions, you have 10 to 14 centimeters of the biceps that you can use for RCR with the biceps in a double strand configuration. The thickness has to be more than 4 millimeters. So the biceps, if you see the same paper, is about 6 to 5 millimeters of thickness. So you can use it if you want both strands. And this is the technique. This is the paper we published as a technical note. And of course, you can read if you want to try for this technique. And this is a nice review paper for a Greek team that looks at RCR with the long head of the biceps has a positive effects Of course, there's no any comparison of the different configurations. It's not easy to compare these kind of configurations. And this is why we need long-term results of the techniques and clinical results. So, long head of the biceps, when we repair large and massive posterior cuff, is a value graft. When exists, when it's not torn or when it's not totally degenerated, we can use the biceps as an augmentation. You can use it as a patch. There's no negative publications for this, but the conclusions are not very strong. And of course, you can use it on the scaffold. We have some positive results biomechanically. And of course, you can use an anterior rotator cap reconstruction as an RCR technique. Thank you very much for your attention.